Welcome back to the Deep Dive. Today, we're taking an in-depth look at a really crucial topic in human development and psychiatry, intellectual disability, or ID.
That's right. We're using the chapter from Kaplan and Sadock's textbook as our guide.
It's a comprehensive source. Our goal today is, well, to give you a clear path through it all.
Exactly. For anyone needing to get up to speed, we want to cut through the complexity. We'll hit the history, the diagnostics, the biology, and the latest in treatment.
Making it accessible, but thorough.
Yeah,
You should walk away feeling well-informed.
definitely.
And we really have to start with the language, don't we? The
Mhm.
history here is, well, it's tough.
It really is. The terminology used historically, cretin, idiot, imbecile, these weren't just clinical terms for long.
They became loaded with stigma.
Utterly. Barr noted they were synonymous with opprobrium and reproach. It reflects that wild historical pendulum swing, sometimes exaltation, but mostly vilification.
Which is why today that people-first language is so incredibly important.
Absolutely critical. It's a person with intellectual disability, not defining them by the condition. It's basic respect and, frankly, clinical credibility.
Okay, so let's unpack the medical understanding. Where did it really begin? I know Hippocrates and Galen mentioned things.
They did, describing variations, but the real turning point, medically speaking, was Esquirrel in 1838.
What did he establish?
He was the first medical writer to define ID specifically as a condition starting early in development, congenital onset. Crucially, he differentiated it from mental illness or dementia that develops later.
And soon after that, we get the beginnings of intervention, right? With Icard.
Yes, Jean-Marc Icard and his work with Victor, the wild child of Aberon, that was a landmark effort.
Even though Icard himself felt it wasn't a complete success.
He did. But the attempt itself, it shifted thinking fundamentally. It introduced the idea that these individuals were potentially educable.
That they deserved focused training.
Exactly, challenging that old view that they were simply beyond help. And that directly inspired the first training schools in the U.S., people like Howe and Wilbur.
But that momentum towards education didn't quite last, did it?
No, unfortunately. By the late 19th, early 20th century, the focus shifted pretty drastically. Away from education towards just custodial care in large institutions.
Which led to decades of, frankly, neglect and often awful conditions.
And that culminated in the 1960s, the exposés, the shocking revelations about places like Willowbrook or Rome State School.
Blatt and Kaplan's Christmas in Purgatory. Those images.
Devastating. That photo essay just laid bare the reality of warehousing people. It shocked the public conscience.
And became a major catalyst for change.
Probably the single biggest catalyst for the deinstitutionalization movement, yes.
But it wasn't just outrage driving it, was it? There was also this philosophy. Normalization.
Right, normalization. The idea, extended by Wolfensberger, is that individuals with ID are entitled to live life with culturally typical rhythms, meaning normal routines, work, leisure, holidays, being part of the community, not segregated away. This philosophy underpinned major legal reforms.
And connecting that to the practical side, the money mattered too. Things like the Katie Beckett waivers.
Exactly right. Those waivers allowed Medicaid funds to support kids with severe needs at home instead of forcing them into institutions.
Because the cost difference was just enormous.
Huge. You look at the figures from, say, 2009 institutional care could cost anywhere from $104,000 to upwards of $375,000 per person per year.
Wow.
So community care wasn't just ethically preferable based on normalization. Often it was and is more financially sustainable too.
Okay, so that shift towards community care really underscores why accurate diagnosis is so vital. Precision becomes key.
Absolutely. Which brings us to the diagnostic revolution in the DSM-5. What's the biggest change listeners need to grasp?
It's the shift away from IQ as the primary determiner of severity, right?
Precisely. The classification now hinges almost entirely on the level of impairment in adaptive functioning.
So let's quickly outline the three main DSM-5 criteria. What are they?
Okay, first, deficits in intellectual functioning. Things like reasoning, problem-solving, abstract thought. Confirmed clinically and with standardized IQ tests like the WAIS or WISC.
Got it. Second.
Concurrent deficits in adaptive functioning. This is the big one.
And third.
Onset. These deficits have to start during the developmental period.
Let's drill down on that adaptive functioning piece. It was formalized by Edgar Dahl way back, but how do we measure it now? And why is it more critical than just the IQ score?
Adaptive functioning assesses how effectively someone navigates daily life demands. It covers three areas: conceptual skills.
Like language, reading, money concepts?
Yes. Then social skills, interpersonal skills, judgment, rule following, and practical skills, self-care, job tasks, managing a household.
And you made a crucial distinction earlier between ability and performance.
Yes, this is key. Adaptive functioning is about performance, what the person actually does consistently in their real life, not just what they can do in a test setting.
So if someone can dress themselves but needs constant prompts,
Then their adaptive functioning in that area is impaired. Performance is what counts for independence. That's why tools like the Vineland scales often involve interviewing caregivers to get that real-world picture.
which can look very different from the IQ scores suggest sometimes.
Often much lower, yes. It explains why some people with relatively higher IQs still need significant daily support.
And these adaptive measures then determine the severity level. Mild, moderate, severe, or profound. What's the breakdown look like?
Well, the vast majority, about 85%, fall into the mild ID category.
Emily?
They can often achieve skills up to maybe a 6th grade level and manage a good degree of independence with some supports.
And at the other end?
Profound ID, that's only 1–2%. It involves pervasive deficits, often needing total care, but, there's a critique of these levels.
That they focus too much on what people can't do.
Exactly. Focusing on deficits rather than also highlighting individual strengths and competencies, it's an ongoing discussion.
Okay, let's pivot to etiology. What causes ID? And maybe more importantly, why is pinpointing the cause so critical? It's not just about giving it a name.
No, definitely not. Knowing the specific cause is absolutely essential. It directly guides treatment, informs necessary surveillance, and crucially helps prevent potentially catastrophic medical errors.
What kind of causes are we talking about?
It's a wide spectrum. Prenatal causes include genetic disorders, Down syndrome, Fragile X are common examples, or environmental exposures like fetal alcohol syndrome.
Okay.
Then perinatal causes around the time of birth, like oxygen deprivation. And postnatal causes things like traumatic brain injury, infections, or exposure to toxins like lead.
But there's still a lot unknown.
Yes, despite advances for maybe 30% to 50% of cases, the specific etiology remains unknown, although genetic testing is rapidly filling in those gaps.
And that brings us to the gene treatment link. This is where knowing the genetics becomes incredibly high stakes. Can you give us those two really stark examples from the text?
Absolutely. First, consider ornithine transcarbamylase deficiency, or OTC deficiency. It's a urea cycle defect, leads to high ammonia levels.
Hyperammonemia. Dangerous.
Very. And here's the clinical pearl. 2 common psychiatric medications, Valproate, used for seizures, mood, and haloperidol, an antipsychotic.
Yes.
They must be strictly avoided in people with OTC deficiency. They can actually trigger a life-threatening hyperammonemic crisis.
Wow. So a standard medication becomes potentially lethal because of this specific genetic condition. That hammers home the point.
It really does. The second example is Smith-Lemli-Opitz syndrome, or SLOS. This involves a defect in cholesterol synthesis.
Okay.
And similarly, 2 other common drugs, trazodone, often used for sleep or depression, and again, haloperidol are contraindicated. They can dangerously elevate a precursor molecule, 7-dehydrocholesterol.
So in both cases, knowing the precise genetic diagnosis is literally a matter of life and death pharmacologically.
Precisely. It dictates what treatments are safe and what must be avoided.
This leads perfectly into the concept of behavioral phenotypes. The idea that a specific genetic cause doesn't just affect intellect, but also shapes behavior in predictable ways.
Exactly. A behavioral phenotype is a pattern of cognitive, behavioral, social, and emotional traits associated with a specific syndrome, occurring much more often than you'd expect just based on the level of ID alone.
Let's explore a few examples from the source. How about Prader-Willi syndrome?
PWS is fascinating, involves genomic imprinting. The classic defining feature is hyperphagia.
Intense hunger.
Yes, a relentless, insatiable hunger likely due to a hypothalamic issue. It leads to a lifelong obsession with food, extreme risk of obesity, and often other compulsions too, like skin picking or hoarding.
And for the most common genetic cause, Down syndrome. What's the behavioral phenotype beyond the stereotypes?
Well, individuals with Down syndrome often show relative strengths in visual processing. Clinically, it's important to look past the always happy stereotype. While studies suggest maybe less severe psychopathology compared to some other ID groups, there's a real need to watch for social withdrawal, especially in adolescence.
Why is that significant?
It can be an early warning sign of depression or even foreshadow the much higher risk of developing Alzheimer's-like dementia later in life that we see in Down syndrome.
Okay. Then there's Williams syndrome, often noted for distinctive facial features.
Yes, the elfin-like features. Williams syndrome, caused by a microdeletion on chromosome 7, has a really striking cognitive profile.
Which is?
Relative strengths in language, particularly vocabulary, they can be very verbal, very expressive, but this often masks severe difficulties with visuospatial tasks like drawing or navigating.
Yeah, absolutely.
They're often described as overly friendly, very sociable, almost gregarious, but this can manifest as significant social disinhibition, a lack of appropriate social boundaries.
Making them vulnerable.
Extremely vulnerable. That stranger danger concept is a major concern.
That really illustrates the complexity. And this ties into that incredible case study about Smith-Magenis syndrome, or SMS, the case of Brian.
Yes, Brian's case is a perfect example of how diagnosis, phenotype, and treatment can align. He was 19, moderate ID, severe self-injury SIB.
And the diagnosis was confirmed as SMS linked to a specific gene deletion.
Correct. But the key clinical insight came from understanding the SMS behavioral phenotype, specifically its disruption of the sleep cycle.
How so?
SMS messes with melatonergic control. Brian had severely fragmented sleep, waking violently around 2 a.m. every night. This lack of proper sleep was fueling the daytime SIB and aggression.
So the treatment wasn't just about managing the behavior directly.
No, it targeted the underlying biological mechanism identified through the diagnosis and phenotype. They used melatonin and propranolol specifically to regulate his sleep-wake cycle.
And the results?
Astounding. His SIB dropped by 90%, the aggression stopped. He was able to learn again, engage in supported employment, live in the community. It's a powerful illustration.
It really is. Now, stepping back a bit, we know that people with ID face much higher rates of mental illness overall, 2 to 5 times higher than the general population. Why is that?
It's multifactorial. The source points to several risk factors. The underlying brain differences, the neuropathology itself certainly plays a role.
Communication difficulties must be huge too.
Absolutely. Difficulty expressing distress, complex emotions or experiences. Plus, there's increased vulnerability to abuse and exploitation, and often inadequate coping skills for life stressors.
So when diagnosing these co-occurring conditions like ADHD, anxiety, ODD, can clinicians just use the standard criteria?
Not directly, no. You have to make modifications. The crucial thing is comparing symptoms relative to the person's mental age, MA, not their chronological age.
Can you give an example?
Sure. Think about ADHD symptoms like short attention span. A 20-year-old with severe ID might function at a 4-year-old level. Their attention span needs to be compared to other 4-year-olds, not other 20-year-olds.
So it only counts as ADHD if it's excessive for their developmental level.
Exactly. Otherwise, you risk overdiagnosing typical developmental behavior as pathology.
Okay, let's talk treatment strategies. The text emphasizes a multimodal approach is best. What are the cornerstones, particularly non-pharmacologically?
The gold standard psychological approach is applied behavior analysis, or ABA. And central to ABA is functional analysis.
What does that involve?
It's a systematic process to understand why a challenging behavior like aggression or SIB is happening. You identify the antecedents, what triggers it, and the consequences, what reinforces or maintains it.
And then you intervene based on that function.
Precisely. You modify the environment, teach replacement skills, change reinforcement patterns, all tailored to the specific function of that behavior for that individual.
Now, what about medications, pharmacotherapy? What are the major challenges here?
The biggest challenge is the relative lack of large-scale, controlled drug trials, specifically in the ID population. Much of the practice involves careful extrapolation from studies in other populations.
And individuals with ID might react differently to meds.
Yes, often they show heightened sensitivity, both to therapeutic effects and side effects. This means the mantra is start low, go slow.
How low?
The text gives the example of starting fluoxetine, Prozac, at maybe 2 milligrams, compared to a typical starting dose of 10 or 20 milligrams in the general adult population. Titration needs to be much more gradual.
To avoid adverse effects.
Yes, including things like paradoxical disinhibition, where a medication actually makes behavior worse instead of better.
And what kinds of medications are most commonly used, and for what?
Well, antipsychotics, particularly second-generation ones like risperidone and aripiprazole, are frequently used for managing severe aggression or self-injury.
But there are risks.
Significant risks, especially tardive dyskinesia, the movement disorder. The rates appear to be substantially higher in the ID population compared to others, sometimes cited as high as 18% to over 30% with older agents. Requires very careful monitoring.
Any other key players pharmacologically?
Melatonin comes up frequently as being quite effective and generally safe for the common sleep disturbances and circadian rhythm issues seen in many syndromes, like we saw in the SMS case.
Okay, this has been incredibly informative, covering so much ground from historical context to cutting-edge genetics. If you had to boil it down, what are the absolute key takeaways for our listener?
I'd say three main things. First, remember that diagnostic shift. Adaptive functioning, not just IQ, defines severity now. Second, always push for an accurate etiological diagnosis whenever possible. It's critical for safe and effective treatment, especially avoiding those dangerous drug interactions.
Right.
And third, really understand the power of behavioral phenotypes and functional analysis. They provide the roadmap for targeted, effective interventions, like with Brian's SMS.
That's a great summary. It brings us to our final thought for you, the listener. This one touches on policy and a debate that's still very active.
We mentioned the IDEA law in the U.S. mandating free, appropriate public education FAPE in the least restrictive environment, or LRE.
The principle is inclusion, educating kids with disabilities, alongside their typically developing peers as much as possible. But here's the provocative question the field still grapples with.
Is that least restrictive environment always the truly optimal setting for every child with complex needs?
Or should we consider that for some individuals, maybe those with very severe behavioral challenges, or profound communication needs, or complex autism, might they actually learn and thrive better in a more specialized, perhaps even separate setting that's specifically designed to meet their intense needs?
It's a tough balance. Inclusion versus specialized support. There's no easy answer, and it continues to shape services and family choices. Something to think about.
Definitely something to mull over. Thank you so much for joining us on this deep dive into intellectual disability.
It's been a pleasure. We hope this was helpful, and we look forward to having you with us next time.